Perfect. So good morning, everyone. We are starting the new year with a bang. Welcome to Nephrology Grand Rounds in Ottawa. We are delighted to have Dr. Ali Husain from Colombia, who is a transplant nephrologist who will be talking to us on kidney biopsies in deceased donors. Dr. Husain he did his internal medicine and chief residency at Tufts, and then he did nephrology fellowship as well as transplant nephrology fellowship at Columbia in New York. He's a recipient of the NKF Young Investigator Award as well as the American Society of Transplant Clinical Career Development Award. He is on the editorial board of KI Reports and an editorial fellow at JASN. He's published a lot around the transplant allocation and stuff in JAMA and many other high-impact journals. So welcome, Dr. Husain.
Thanks so much, Swapnil, for the invitation. It's really an honor to be speaking here today. And I was telling Swapnil, this is like a topic that's narrowed in time, but I think it allows a little more depth, and hopefully it'll be of interest to both the transplant folks in the room and also general nephrologists as we talk a little bit about kidney biopsies in general. But first, for my disclosures, I have no relevant financial conflicts of interest. And essentially in this talk, what I'll try to do is answer what I'll call here the fundamental question. So imagine you have a 51-year-old woman, a deceased donor you're evaluating. She's a donor after cardiac death. Her creatinine, when she comes into hospital and dies, is 1.8 milligrams per deciliter. You have no prior information about her. You know nothing about her medical history. She hasn't seen a doctor in years, so you have no baseline labs. The question is, when you have a marginal donor like this, if you biopsy her kidneys and get the results on the left, so very minimal glomerulosclerosis, basically no interstitial fibrosis, tubular or vascular disease, does that portend a better prognosis than if you get biopsy results on the right, which is a little bit more glomerulosclerosis and then mild to moderate tubular atrophy and interstitial fibrosis and moderate vascular disease? Right? So it should be a simple question, but maybe not so simple in reality. To answer that question, we'll do a few things. So we'll talk a little bit about why we need improved organ quality assessments, the current deceased donor kidney allocation biopsy practices in the US predominantly and a little bit abroad, how allocation biopsies influence organ utilization, what evidence we have for that, and then finally what the evidence is for or against any prognostic utility of these biopsies in deceased donors. And I think the most kind of complete set of data is for the US, so I'll mostly talk about US data, but I'll talk a little bit where we're relevant about some other places as well. But to start with, kind of to frame you a little bit from the United States perspective, you know, there's obviously a huge shortage of organs available for transplant. Here, you can see the green line here is all candidates added to the waiting list annually. The gray line is the number of deceased donors, deceased and living donor transplants performed. And you can see that the area between that curve is very, very large, right? Everyone who's in between those two lines, someone who's going to die on the waiting list without a transplant. Currently, that's about 20,000 patients per year who are added who will never get a transplant. And unfortunately, as we try to expand the kind of access to transplant to meet that need, any increase that has occurred has been from deceased donor transplants. Here you can see the bottom line is living donor transplants, which has basically been flat over the past 2 decades before COVID. COVID kind of threw a wrench in everything, so I usually cut off my data presentation right before COVID. But totally flat, whereas any increase in that blue line, total transplants, is driven by the green line, which is deceased donor transplants. And that's exactly true of Canadian data as well. So for you, you can see here, same red line, deceased donor transplants has been basically flat over time, whereas that increase in total transplants is driven by an increase in deceased donor transplants. And there you can see on the bottom, you know, annually in Canada, there's just over 1,700 transplants, but 2,800 people waiting on the wait list. So clearly a huge kind of supply-demand mismatch. And that increase in deceased donor transplants has been from marginal kidney donors. So for example, for donors after cardiac death, there were only 59 in Canada in 2011, whereas there were 240 in 2019. So more than a 4-fold increase in just that one kind of undesirable characteristic. So in that context, assessing organ quality becomes very, very important as we rely on these increasingly marginal deceased donors. So we got to be able to answer a few questions about a given donor. So one is, should that kidney be transplanted at all? You know, is it worthy of transplantation, or does it have too low of a quality to even transplant? The second is, if it is transplantable, who should it be allocated to? You know, is it good enough quality to give to a young donor or young recipient who will have a long expected lifespan, or is it better served in an older donor with a shorter expected post-transplant survival? Then finally, just a general sense of what we should expect out of a given kidney. So when we transplant it, and kind of we get a given set of clinical characteristics or a nadir creatinine that's slightly high, we know, is that something that we might expect or something going wrong? Unfortunately, objective measures that we have of kidney quality are fairly limited. So historically, what you guys might be most used to, especially people who have been here the longest, was this characterization of ECD or extended criteria donor status. This was based on either having an age of 60 or above or an age of 50 or above with 2 of the following 3 characteristics of hypertension, high creatinine, and death from stroke. In the US, that's been replaced by something called the Kidney Donor Profile Index, which is a scaled score based on 10 donor-specific characteristics that you can kind of input, and it gives you a score from 0 to 100%, indicating the percent of donors that are better than this donor. So 100% KDPI means that every other donor is better. It's kind of the worst quality kidney, and generally we consider the top 20%, so 0% to 20%, to be very good quality, and the worst 15%, so 85% to 100, to be the worst. The problem is that of these characteristics, some may not be known or stable, right? So if we think about our patient who's the donor in the fundamental question, we don't know if she has hypertension. We don't know if she has diabetes. Her creatinine might be changing around the time of death. And so what that requires is a little bit of uncertainty to be kind of put into these equations. So the way we do it in the KDPI is we kind of give population level estimates of the prevalence of hypertension and diabetes, but that's obviously not particularly accurate for an individual person, even though it might be accurate at the population level. And so if we take someone like our donor, her KDPI is 74%. So, I mean, she's like in the worst 26% of donors. But if we kind of change the amount of information we have, so we figure out she has no hypertension, she has no diabetes, or we kind of get confirmation in the other direction that she does have diabetes, let's say, or hypertension, or her creatinine goes up or down right around the time of death, suddenly that number can change a lot. And you can see on the right there that will kind of dramatically change her estimates of graft survival. So that uncertainty obviously is problematic, as is the fact that the C statistic for KDPI is only 0.6. So really explaining a very, very small percentage of the variation in allograft outcomes post-transplant when we're using deceased donors. And then further, a problem with these kinds of scores is that real-life organ quality might not match up to what we see in the KDPI. Like, so for example, this is an indication of just all donors in the US, a graph of all donors in the US based on their KDPI versus their age. That we had presented for a different discussion about pediatric prioritization. But you can see there is that kind of some donors, what we might consider to be really excellent donors. So for example, a 16-year-old donor, many of them will have a high KDPI because of the relationship between height and weight in the equation with the scaled KDPI score. So we get kind of some funky things as we try to incorporate kind of a holistic estimate of organ quality based on only 10 characteristics. So we might think that maybe in the absence of a little bit more information, that KDPI could be helpful, but that we can incorporate our own gestalt of organ quality. But unfortunately, we know that that's not particularly accurate as well. And in fact, we must appreciate that our own sense of organ quality above things like KDPI doesn't really add much. So here's a study we did looking at whether the sequence at which a kidney was placed is indicative of expected post-transplant outcomes. So in other words, a kidney is very rarely accepted by the first person on the waiting list, just because they have the kind of leeway to wait for kind of a better offer potentially, since they're the first in line. And so we looked at whether a kidney with the same KDPI that was accepted among the first few candidates whom was offered, whether that does better than a kidney with the same KDPI that takes 100 or even 1,000 candidates before the offer is accepted. What we found is that basically, unless you get to the very, very, very late sequences, to greater than 1,000 candidates turning it down before acceptance, there's really no explanatory power of sequence of placement, or basically clinician willingness to use the organ after you incorporate KDPI alone. And even that effect of being in the 1,000th or greater sequence number was very small, right? And has a ratio of only 1.16, despite this dramatic difference in willingness to use from the clinicians. And in fact, if we look at kidney pairs from the same donor, in which one kidney was transplanted and the other was not, we see that except for the best quality organs, the reasons for discard are things that should be similar for both kidneys. So for example, donor history is obviously necessarily similar for left and right kidney. Kidney function is the same for left and right kidney. Biopsy findings, as we've studied, tend to be similar between the left and the right side. So despite that similarity, often kidneys are from one side of a donor are not utilized, where the contralateral kidney in the pair is transplanted. And if we look at kind of the outcomes of that, which might indicate kind of clinician gestalt about, okay, this donor is a little bit worse than his history might indicate, we see that medium-term outcomes for kidneys for whom their partner kidney was transplanted versus their partner kidney was discarded are basically the same. So kind of that extra information about what happened to its mate kidney is not informative. And this is not really anyone's fault, right? So it's based on just limitations on how people think. Humans make very weird decisions under uncertainty, and they tend to be more risk averse when they have uncertainty. And we see that in kind of other data points. So you guys might be familiar with what's called the left digit bias. So this is information, kind of an information problem that sellers use when they're trying to get us to buy things, where they might price an item, for example, for $2.99 versus $3 to make you think, oh, it's in the 2s versus in the 3s. The same thing happens, that same cognitive error happens when we evaluate donors. So for example, donors who are age 70 have a much higher even adjusted rate of organ discard than those who are age 69, despite that 1 year of age difference, as you can see on the left of your screen, being very minimally important. And the same thing happens around a donor creatinine of 1.9. So if creatinine is 1.9 versus 2 milligrams per deciliter, it's essentially the same kidney function, but you get a big pop-up suddenly of non-utilization just because that cognitive error. So we need to overcome these cognitive errors, of course. But in the meantime, we have to acknowledge that there's a huge deleterious impact on access to transplant of this challenges of utilization. So here on the left is US data, before and after our most recent allocation system update in 2021. What you can see is that the monthly discard rate for kidneys that were recovered for the purpose of transplant. So this is kidneys where the deceased donor was suitable, consent for donation was obtained, the kidney was physically recovered for transplant, but then offered, not used. That's approaching 30%. So getting to the point where almost 1 out of 3 of kidneys that are actually recovered are not used for transplant. As you can see on the right of your screen here, that impacts kidneys of basically all qualities, except for the very best. So that top red line is kidneys with a KDPI 85 to 100%, so the lowest quality donors. Up for them, more than 2/3 are not used. But even in that middle quality, so 21 to 84%, so really the bulk of kidneys that are offered, almost 1 in 4 are not used for transplant after being recovered for transplant. At a patient level, there's a huge consequence in terms of the fact that many patients for whom organ offers are declined suffer adverse outcomes. So in fact, we previously showed that at a national level, 30% of waitlisted candidates who receive at least one offer for a deceased donor kidney transplant that was ultimately transplanted in someone else. So they get an offer, it's turned down on their behalf, someone else accepts it and is transplanted. So 30% of those candidates ultimately die on the wait list or are removed from the wait list without getting a transplant for being too sick. And it's not even like they only get 1 or 2 offers during their time on the waiting list. They get a median of 16 before dying on the wait list. So multiple opportunities for transplant over a long extended period of time before eventually dying on the waiting list, because their clinicians aren't kind of adequately capturing quality of kidney versus risk of remaining on the waiting list. So then, with that being said, the question is, can tissue help improve our assessment of organ quality? And so before we get into that, we're going to do a quick pause for just a few definitions of different kinds of biopsies that you might encounter, and we'll talk about briefly. So the first is allocation biopsies, or also known as procurement biopsies or pre-implantation biopsies. So these are biopsies that are performed during the deceased donor kidney allocation process to help inform allocation decisions. These are in contrast to implantation biopsies that are performed very commonly in Europe, and we do them at Columbia as well. These are also known as reperfusion biopsies. These are biopsies that are performed after kidney allograft implantation and allocation following allograft reperfusion. So they cannot help with allocation because the kidney is already in the recipient, but they can help just assess the organ histopathologically. So the the rationale behind doing an allocation biopsy in the first place is that the degree of chronic changes is hypothesized to provide independent additional assessment of the kidney quality and long-term prognosis above clinical characteristics alone. And that's something that we should be used to in terms of routine nephrology practice, right? So imagine, for example, a non-transplant scenario. You see a 27-year-old woman comes to clinic. She has a history of lupus. She hasn't been seen in about a year. no recent labs, and her creatinine is 4.1. If you biopsy this patient and find diffuse endocapillary hypercellularity with a high degree of glomerular sclerosis and a high degree of IFTA, as you see on the left, that might cause you to have a different treatment paradigm than if you biopsy her, see the same histopathologic lupus class, but have a lot less scarring. In fact, you might treat her differently in terms of the intensity of immunosuppression, and you might give her a different prognosis in terms of what you're going to expect for her kidney recovery. And that's a decision that's very strongly based in evidence. So this is one example, but this is 676 individuals from the Boston kidney biopsy cohort. I'm not involved in the study. But basically, they looked at 676 for-cause biopsies and examined whether the degree of chronic changes on these biopsies was associated with either 40% decline in GFR or initiation of RRT as a combined clinical outcome. What they found was that increasing glomerular sclerosis, increasing IFTA, and increasing vascular disease were each associated with a higher risk of progression of kidney disease, even after adjusting for other clinical characteristics. And those were kind of associated with worse prognosis in a stepwise manner. You can see there on the bottom. The more chronic changes you get, the more you have a risk of an adverse outcome. This is similarly true in data from the Mayo Clinic. So this is almost 1,000 radical tumor nephrectomies. And what they did is they performed large wedge biopsies of these tumor specimens and again, examined the degree of chronic changes, chronic scarring. What they found was, again, higher degrees of IFTA, higher degrees of glomerular sclerosis, even 5% or more, are associated with a higher risk of that same outcome of 40% decline in GFR, or the need for a dialysis transplant, or GFR of less than 10. So one question, though, is how many of these findings are really incidental findings? And so that's a hard question to answer, right? Because some people will have chronic changes that increase as a result of advancing age. Here you can see that this is data, sorry, I forgot to include the citation, it's on the next slide, from our living donor cohort. What you can see is that among kidneys from living donors that undergo an implantation biopsy, 14% of them have some chronic changes on the biopsy. And in fact, 1% even have findings consistent with donor glomerular nephritis. And so not all the changes might be pathologic because these are people who have normal kidney function, right? And are screened heavily for evidence of kidney damage. Sorry, just recovering from a lost voice. And what we see in these living donors is that among these living donors, if we look at the relationship between the degree of chronic changes and their renal outcomes, there is no association between having more chronic changes or having even glomerular nephritis on their implantation biopsy and worse renal outcomes for the donor after donation. So you can see on the left here, that's percent eGFR loss at 6 months. On the right is single kidney eGFR gain. You can see basically no significant difference between groups. So hopefully with that equipoise a little bit established, let's talk about how kidney biopsies are used in the US. So so this is data from Krista Lentine from St. Louis. She showed that basically among kidneys recovered for transplant in the US, just over half undergo at least one biopsy during allocation. But there's huge practice pattern heterogeneity here, whereas some organ procurement organizations that are charged with kind of organ recovery in a local area, some biopsy as few as 23% of their organs, whereas some biopsy as much as 78%. So obviously a huge difference here. If we look at kind of whether that heterogeneity is similar across different type of organ quality, we see that it's really not. So on the left here is biopsy, on the left of your screen here is biopsies rates for kidneys with the best KDPI. So 20% of best kidneys recover for the purpose of transplant. What you can see is that there's huge variety. Most people are not biopsying these kidneys frequently, but some are biopsying as many as greater than 60% of them. Whereas on the right, you can see for the worst 15% of kidneys, almost everyone is biopsying almost all of these kidneys. If we further try to understand kind of where the heterogeneity is for the non-worst quality kidneys, we need to understand basically what OPOs are using as their triggers for performing biopsies. Here's data from a survey we did of OPOs, organ procurement organizations, as a reminder, asking them what triggered their criteria for biopsy. And essentially all of them either had some formal criteria or or alone, or some form of criteria, but also allowed centers to request biopsies on kidneys that didn't meet their formal criteria. So basically a shared decision between the OPOs who might decide, okay, this kidney needs more information, as well as the organ transplant centers who are also saying, I need more information before accepting this kidney. And in a different survey, we asked, okay, centers, how do you think these biopsy decisions are made? They said the same thing, basically. It's a shared decision between the transplant centers and OPOs, and they largely rely on specific donor characteristics when they're deciding whether or not to request a biopsy. And this is important because the biopsy criteria between OPOs and centers is actually fairly similar. So the criteria to perform a biopsy reported by OPOs are things that we might expect, right? So things that impact kidney function or influence risk of chronic kidney disease. So things like higher creatinine, donor acute kidney injury, donor diabetes, hypertension, or ECD status. All these things, right, make a donor marginal and might make us want more information. Similarly, centers, so again, this is a survey of 95 centers. Similarly, centers report things that they are looking at are clinical characteristics associated with higher risk of kidney disease or worse kidney function. So age, acute kidney injury, and diabetes are the most commonly requested things. And I promise you this will come in handy as we advance this discussion. And then finally, from a technical standpoint, if we ask OPOs kind of how they do these biopsies, what they tell us is that they predominantly do wedge biopsies. You can see that 92% do either only wedge biopsies or a combination of wedge and core biopsies. 98% either do frozen section biopsies alone or a combination of frozen and permanent sections. And then just over half the time, they're having these biopsies read by pathologists who don't have any renal expertise. So kind of not entirely similar to the kind of biopsies we use in clinical practice that I said there's strong evidence for, right? And when we take that into account, that helps understand why people have been very negative about biopsies and kind of complaining that maybe they adversely impact allocation. So to sum up a criticism that's been not only in the US, but throughout the basically entire global transplant scene, the concern has been that allocation biopsies increase the risk of kidney discard or non-utilization without providing additional prognostic information about organ quality beyond what's already known from clinical information. So we'll talk about each of these two clauses in the criticism, the red and the pink one, kind of in tandem. I think they're both particularly important when we decide, okay, do we want to discourage the use of these biopsies during allocation? First, let's talk about whether biopsies actually increase the risk of non-utilization. So this has been a big question, concern over the past few decades, because you can see here, this is the reason cited for an organ that was discarded. You can see here is that almost throughout the entire of transplant history in the US, unfavorable biopsy findings have been cited as a #1 reason for organ discard. And that's really something that's only changed in the last couple of years under the newest allocation system, in which kind of placement difficulties have taken over. If we look at the rise in biopsy use, which is the top panel here, you can see actually it very strongly correlates to the rise in discard rate over time as well. And this has been kind of shown as potential correlational data saying that the two factors are related. So you can see here in the top panel, I try to line up the black lines for different years, but kind of as biopsies are increasing, discards increasing. As biopsy rates stabilize after 2010, discard rates also semi-stabilize for a short period of time. So certainly some strong correlative data that's unfortunately counteracted by some other correlative data that in the opposite direction. So this is the same slide I showed you earlier about heterogeneity in biopsy performance. What you can see is that all the way on the left of this figure, so the OPO that performs the highest portion of biopsies in terms of the tallest yellow line or gold bar, their discard rate is almost identical to that of the OPO all the way on the right. So the one that performs the fewest proportion, the lowest proportion of biopsies. So clearly not a strong correlation at the OPO level of performing a biopsy and utilization rates. And in fact, if we look at kind of kidneys at the highest risk for discard, so the high KDPI kidneys, among them, discard rates, biopsy rates are not at all correlated with discard. On the left panel is just raw rates. On the right is adjusted odds ratio of discard. So no relationship between getting a biopsy, period, regardless of results, and utilization. And it's only really a strong relationship on the left among those very low KDPI kidneys that are high quality. But again, remember, very few of those kidneys are biopsied, so clearly an opportunity for selection bias here. If we ask centers how they use results of biopsies, really the risk of increased discard is the scenario on the left. So if you take a center, give it a standard criteria kidney, so a good quality kidney, they do report that often a bad biopsy will persuade them to decline a kidney that they otherwise might have used, a standard criteria kidney. However, the value of biopsies is seen in the right side of the panel. So we asked centers, what about a kidney with marginal clinical characteristics? So remember, I told you that the proportion of donors from DCDs who are DCDs in Canada has like quadrupled over the past 10 years. So among them, they often will tell us a good biopsy will persuade them to transplant a kidney they otherwise might not have used based on clinical characteristics alone, whereas a bad biopsy will persuade them to decline these kidneys if they have bad clinical characteristics. So basically, presenting an opportunity to rescue kidneys that are otherwise at a high risk of non-utilization. And kind of we don't really have, unfortunately, a lot of prospective data on kind of confirming that impact of biopsy performance or biopsy results on utilization. But what we do have is two kind of interesting and important studies, one from the US, one from Canada. So first here is a simulated organ offer study of 41 kidney transplant surgeons, 21 transplant nephrologists who received kidney offers in real life. And they each received the same 20 hypothetical kidney offers. And so I'll walk you through the slide because it's a little bit complicated. So on the left here, you can see that the red, yellow, and green bars are three different scenarios for donors with the same clinical characteristics. So it's a donor who has a low serum creatinine, less than 1.5, otherwise favorable clinical characteristics. The red bar on the left is kind of giving that same characteristics with quote unquote bad biopsy findings, so high degree of chronic changes. The middle is presenting the same donor with no biopsy results at all, and the right is with good biopsy findings. What you see is that providing good biopsy findings doesn't really improve utilization rates because they've already decided basic clinical characteristics alone, and the biopsy results are confirming their initial impression. However, in these kidneys, providing bad biopsy results decreases utilization. So this is what I was talking about, that risk, right? You have otherwise transplantable kidney giving bad information that might not be necessary to know worsens utilization rates. On the other hand, on the right panel, if you look at a donor with bad clinical characteristics, unfavorable characteristics, so that with a kind of a creatinine of greater than 2.5 and rising. So centers are more or less unwilling to use these kidneys. You can see on the yellow panel with no biopsy result, very low utilization rates, unless you provide a biopsy that's favorable, there on the right of your screen, in which case utilization rates dramatically increase. So again, potentially an opportunity to rescue allocation of these bad kidneys, but maybe not doing any good in the standard criteria kidneys. That's similar to results from a Canadian survey of transplant physicians, in which I'll have you focus on just the last two boxes on the right. So this is a donor with different characteristics and looking at acceptance rates based on change in characteristics and from providing biopsy results. If you look at the last two biopsies, the two rightmost ones, we take a donor with unfavorable characteristics in scenario 3 with kind of so-so biopsy findings. So 25% glomerulosclerosis, no vascular disease. You do not see any improvement in utilization rates when you present that same information with no biopsy. So clearly the biopsy is not what hurt the utilization here. In fact, the biopsy is just capturing the same information that we know from clinical characteristics, and removing it does not improve utilization rates. Right? So certainly, hopefully compelling evidence that it's not clear that getting a biopsy at all will increase non-utilization across the board. So with that said, let's start to put everything together to answer that fundamental question I showed you earlier about whether that biopsy in certain scenarios can be helpful. So importantly, I would like to kind of bring you back to some differences that I showed you earlier about differences between biopsies performed during allocation and other clinical biopsies done for cause in routine clinical practice. So as I told you, allocation biopsies are typically white samples, frozen sections with a single stain, read by non-renal pathologists under a lot of time pressure. This is totally a different scenario than other kidney biopsies performed in routine practice, which are typically needle core sections, FFPE process, so formalin fixated and paraffin embedded, with 4 or more stains, read by trained pathologists who have plenty of time to sit down and kind of think about the findings they're looking at. So before we can incorporate kidney biopsy into allocation, we need to understand do these biopsies actually yield reliable histologic assessments despite those different technique compared to regular kidney biopsies? And which, if any, biopsy findings that we can see on these specific types of biopsies are associated with adverse post-transplant outcomes? So first, let's talk about biopsy reproducibility. So one thing we know is that wedge biopsies are potentially really bad at providing reproducible assessments of chronic changes, probably because there are these wide sections that oversample that superficial subcapsular tissue. So you think the shape of a wedge, kind of the wedge is widest right at the underneath the cortex, right underneath the capsule. So you're going to get a lot of that subcapsular tissue. And in fact, here's a study from 2000, so a very old study, kind of already establishing this more than 2 decades ago. They took 9 kidneys from 5 different donors. These kidneys were discarded because of unfavorable biopsy findings. And what they found was that if you take those biopsies, perform serial wedge sections on them, the different wedge sections give very different estimates of glomerular sclerosis. And we can see, I highlighted in that pink box kind of some of the more dramatic ones. If you take the subcapsular glomerular sclerosis, which is oversampled, it's sometimes almost triple that of the mean section glomerular sclerosis in the deeper sections. So clearly where you're sampling has a big difference. And in fact, we looked previously at a cohort of 606 kidneys, that underwent multiple procurement biopsies during organ allocation. And whether there's agreement between the first biopsy and the second biopsy, typically these are performed only a day apart. What we found was that the correlation between glomerular sclerosis on the first biopsy and the second biopsy was very, very poor. So R squared of only 0.12. Basically, you're performing 2 biopsies on the same kidney, getting totally different results for glomerular sclerosis. You can see here, sometimes the first biopsy showed 50% glomerular sclerosis, and the second biopsy showed none. So a lot of sampling error. This is true also of things like vascular disease and IPTA, which might be kind of more important in some certain circumstances. We can see that the kappa values for glomerular sclerosis, for IPTA, and for vascular disease, you can see on the top of each of these boxes, is as low as 0.12 and 0.17. If you remember, your kappa value is going to vary from 0 to 1, with 1 being perfect agreement, 0 being the worst. So very low agreement between first and second biopsies of the same kidneys performed essentially a day apart usually. Further, beyond kind of just kind of sequential biopsies being performed, providing different results, the pathologist who reads it can really impact what is seen on the biopsy. So this is data from Barcelona. I was not involved in the study, but it's a really fantastic classic study showing this. It's 102 extended criteria donor kidneys recovered in Barcelona and transplanted. On the left, you can see reads that were done by the on-call pathologist who actually read the biopsy specimen, and that read was used for allocation, compared to reads done by a renal pathologist on the essentially the y-axis of that 5x5 table, read by a renal pathologist who's trained in renal pathology. Right, what you can see is that there's very different assessments of the degree of chronic changes as interpreted on the same slides by the on-call non-renal pathologist as a renal pathologist. But more importantly, look at the right of your screen. There's really different prediction of outcomes when that biopsy is read by a renal pathologist versus a non-renal pathologist. So in the kind of the left side set of box and whisker plots, you can see that as you see increasing chronic changes seen by the on-call pathologist, there's no difference in post-transplant renal function at 12 months. Whereas all the way on the right of your screen, as the renal transplant pathologist sees an increasing amount of chronic changes in that biopsy specimen, that's associated with a stepwise lower 1-year GFR. So clearly predictive of post-transplant kidney function, whereas the on-call pathologist reads were not. And this is important because, like I told you, most centers in the US and abroad are using on-call pathologists who are not necessarily renal pathologists. Unfortunately, there's also some equipoise here. So here's data from over 400 biopsies performed in performed on transplants done at our center, and we compared those that were performed with wedge versus core sectioning, and those that were read by renal versus non-renal pathologists before being accepted here. And we compared their kind of histologic chronic changes to chronic changes that were seen on that same kidney basically the next day during reperfusion. So kind of gold standard biopsies that were needle core biopsies, FFPE, well stained and read by the super experienced renal pathology group at Columbia that reads basically 1 in 5 kidney biopsies that are done in the entire US, right? So kind of a nice gold standard histology. Even among wedge and core biopsies here, there was no difference in the association, no difference in the concordance with gold standard histology. And when we looked at kidneys that were read by renal pathologists versus non-renal pathologists, there was no difference in the, again, kind of pathologist read being similar to the gold standard histology seen in the reperfusion biopsy the next day. So maybe at a larger level, not perfectly predictive. Although kind of some confounding factors are probably the fact that here, for example, in New York, our renal pathology slides for deceased donor kidney biopsies are not read by renal pathologists, but they're read by a super experienced group at Mount Sinai who's reading a lot of these biopsies. So maybe not renal pathologists, but still a lot of experience doing this one particular thing. Finally, I think it's important to understand that even what we call gold standard biopsies themselves have some limitation in their reproducibility. So here is data from 69 kidneys that were biopsied as by protocol after transplant at our center. So at our center, if you have pre-formed donor-specific antibodies against your donor, you undergo biopsies at day 0, 7, 14, 1 month, and then sequentially at certain time points afterwards to kind of do rejection surveillance. So we said, okay, between day 7 and day 14, there should be a very small amount of progression of chronic changes. So we can kind of use them as checks against each other in terms of interpretation of chronic scarring. What we found was that there's really different results of glomerulosclerosis, IFTA, and vascular disease between biopsies performed at day 7 and day 14, and they go in both directions. So sometimes day 14 had more scarring, sometimes day 7 had more scarring, and this is true even in the absence of ATN, even in the absence of rejection. There's just not good kind of reproducibility of this finding of chronic changes. So the question is, okay, let's say we can get our biopsy results to be sufficiently reproducible. There's still the issue of deciding what we should be caring about. So when we asked OPOs what they present in their biopsy reports, they largely focus on glomerulosclerosis. And this has historically been cited as one of the things that transplant clinicians look at the most. They care about the glomerulosclerosis, but they also care a little bit about things like interstitial fibrosis, tubular atrophy, and vascular disease. And really not some other things that we as nephrologists might think are important all the way on the bottom of the screen, right? So like glomerular capillary thickening, changes in the mesangial matrix. No one really cares about that or even reports it. One issue with that is that glomerulosclerosis might be double counting things like age. So here again is data from the living donor cohort at Columbia. And what we did is we identified over 1,000 living donors whose kidneys were transplanted and biopsied upon reperfusion. So basically what that provides us with is an assessment of chronic changes in a super healthy population that we know has normal kidney function and that has no evidence of kidney damage kind of clinically, right? So proteinuria, things like that. In this group, you can see that glomerulosclerosis increases with increasing age. And in fact, if you look at the group of patients who are 60 or older, who have no hypertension or smoking history, so that's the rightmost part of your table, the bottom line, you can see that among these super healthy people that kind of are the pinnacle of kidney health, who are in their 60s, 5% of them have greater than 23% glomerulosclerosis. And even among those in their 50s, 5% have more than 20% glomerulosclerosis. So a really high degree, quote unquote, high degree glomerulosclerosis, even in a very healthy population, right? And no one would turn down a living donor transplant from a super healthy 50-year-old just because they found out they had 20% glomerulosclerosis. Unfortunately, centers don't really take into account this association between age and higher degree of scarring when they set their internal and external filters about which kidneys they're willing to use. So in the US, centers are able to use filters to automatically decline kidney offers that are offered to them based on pre-specified clinical characteristics. So if you say, for example, I'll never transplant a kidney with 50% glomerulosclerosis, you can set a filter saying, don't even give me that offer. Don't wake me up for that in the middle of the night. So here you can see that both in 2007 and 2019, so across a very large period of time, the most common threshold to automatically decline a kidney is glomerulosclerosis of 20%, regardless of the age. And that should be shocking to you based on data I just showed you, because 20% glomerulosclerosis in a 40-year-old, 20% glomerulosclerosis in a 65-year-old are two totally different findings, right? So clearly not being incorporated well now. If we look at nephrosclerosis more broadly. So this is data from the Mayo Clinic, who has a very kind of fascinating set of work on their living donor biopsies that I really encourage you to read from Andrew Rule and Alexander Denick. What they found is that, again, nephrosclerosis increases with age. And if you take a living donor who has a certain age and kidney function, sorry, a certain age and nephrosclerosis, they have the same kidney function on average as a donor of the same age without nephrosclerosis. So basically, nephrosclerosis is not indicative of kidney function, and not independent predictor beyond age. And we kind of reproduced this study with our living donor cohort in Colombia, again, over 1,000 living donors whose biopsy results are available to us. And again, among all donors, or even the healthiest donors with no hypertension or smoking, there's no association between nephrosclerosis and the relationship between eGFR and donor age. So really not clear that in a healthy population that it's providing a lot of extra information beyond age. The thing is, though, that age-related glomerular sclerosis and other chronic changes are largely superficial. And that's kind of one issue with our wedge biopsies, is that, so then, again, this is kind of data from this Mayo Clinic group. What they showed is that essentially on the bottom of your screen, you can see that age-related glomerular sclerosis goes up a lot with advancing age in that superficial layer, not as much in the deep layer. Whereas things like disease-related glomerular sclerosis associated with hypertension, diabetes, and other pathologic loss of nephrons kind of affects the full depth of the kidney, kind of more fully. And so maybe these wedge biopsies, which oversample the subcapsular tissue, are one part of the problem. The other issue is that perhaps focusing on these chronic changes alone are kind of misleading us, because they are kind of things that are most influenced by things like age, which we already are able to understand clinically when we get a donor offer. Whereas other microstructural features, so things like non-sclerotic glomerular tuft volume, or other kind of microscopic features of the glomerular microstructure itself, they don't change with age, right? And that's been shown really well by this Mayo Clinic group, that as we age, single nephron GFR stays the same. Decrease in GFR with age is due to kind of nephron senescence, but the nephrons that are left behind are normal nephrons. We tend to just lose them as we get older. So kind of understanding whether the nephrons that we're seeing, the glomeruli we're seeing, are microstructurally normal might actually provide more information. So unfortunately, most of the evidence we have about whether biopsies kind of actually provide some extra information, kind of with all that kind of technical stuff behind us, is reliant on like very retrospective, poor quality data. And so the typical study looks something like this. We have, and this is our data from Colombia, we have kind of biopsies performed on a few hundred deceased donors during allocation. There on your left, you can see that when we looked at those biopsies that were done after reperfusion, so these great high quality biopsies, the reperfusion biopsy showed us that a higher degree of scarring was associated with lower allograft function and lower allograft survival over time. Whereas if we flip to the right side of the screen, those same kidneys, when the biopsy is performed during allocation, instead, these kind of low quality wedge biopsies that are kind of frozen sections, they had no association between higher degrees of chronic changes and worse allograft function over time. And this is something we've tried to overcome, because obviously that kind of retrospective data is subjective to a lot of biases, right? So one thing we tried to do was look at paired kidneys from the same donor. So here we looked at over 1,500 deceased donors of more than 3,000, obviously, transplanted kidneys who had discordant right kidney and left kidney procurement biopsy or allocation biopsy classification. And what you can see is that if you have a donor whose one kidney has more scarring, the other does not, there's basically no association on the left, you can see, with graft survival, and a minimal association with patient survival. And that should be interesting to you in terms of wondering whether our retrospective studies, our retrospective studies that we rely on, are biased. As you can see on the bottom of your screen, in adjusted models, there's actually a pretty strong association between histologic findings and patient survival, right? And so what that tells you is that perhaps we're putting kidneys with more or less scarring into different kind of recipients. And that introduces a selection bias that might impact our assessment of allograft outcomes. And in fact, we get similar kind of concerns about kind of the null association between biopsy findings and allograft longevity being due to bias when we look at other kind of sub-cohorts of special kinds of kidneys that were biopsied. So here again is data from those 600 odd kidneys that were biopsied multiple times before being transplanted at Columbia. And what we saw was that the first biopsy that were performed, typically outside of New York, they had no association with outcomes, right? But if we look at the second biopsy that were performed, they did have an association with outcomes. In fact, a higher degree of scarring was very strongly associated with inferior allograft survival. And so the fact that one group of biopsies is predicting outcomes and the other is not should really pique your interest of kind of how good is the quality of this data on the same kidneys we're getting discrepant results. And kind of I think the classic kind of demonstration of this is a study that was published now almost 2 years ago. This was by far the best retrospective study done on the association between kidney biopsy findings and allograft outcomes. It was almost 4,500 extended criteria donors, required a lot of manual extraction. This was done by UNOS and University of Virginia. So a huge group of people doing a lot of work. And what they found was that, if you look at that blue line, increasing glomerular sclerosis was associated with a higher risk, higher hazard, I should say, of graft failure, but only up to a glomerular sclerosis of 10%, beyond which there's no further association. And that should be a finding that you find very interesting, because how could it be mechanistically plausible that 5% glomerular sclerosis is way better than 10% glomerular sclerosis, but 10% glomerular sclerosis is no better than 30% glomerular sclerosis, right? It's just not sensical. And kind of the kind of proof that there's something weird going on that should cause us to not rely on our retrospective data is in these green dots. The green dots you see here are the discard rate at each glomerular sclerosis level. What you can see is that when you get to glomerular sclerosis of 20% or more, the discard rate exceeds 85%. And so what we're doing is we're removing kidneys that are at highest rate of discard and also at the highest rate of failure, right? Low quality ECDs that have a high degree of glomerular sclerosis. And so we're distorting our association with outcomes. And kind of what you might see, kind of if you think about it conceptually, is that we're enriching our cohorts for kidneys that have good biopsies but bad outcomes. Because we're either not biopsying the kidneys I showed you earlier from Crystal Lentine's data, we're not biopsying often the good quality kidneys that are going to have good outcomes. And we're not really transplanting the kidneys that have bad biopsies. And so our cohorts in these retrospective studies are completely biased. And we showed that kind of, and tried to show that, I should say, in a couple ways. So here is the proportion of kidneys that are recovered that have kind of advanced chronic scarring in terms of glomerular sclerosis if they're vascular disease. You can see if you look only at kidneys that were actually biopsied and transplanted, there is no association between worse kidney function and a higher degree of scarring. But instead, if you impute that kidneys that didn't undergo a biopsy had favorable findings because they didn't get biopsies, so they must have been good, you see that a higher terminal creatinine is associated with a higher degree of chronic changes in a stepwise fashion. So basically just an indication that we're missing something here. And in fact, if we isolate the assessment of outcomes to kidneys that are both at a higher rate of being biopsied and transplanted, so good quality kidneys with a donor creatinine between 1 and 2, in the middle of your screen here, that both will get biopsied because they often get biopsied, but also are going to get transplanted likely no matter what, there's a clear association between advanced scarring on the biopsies and worse allograft survival that is not seen in the lowest quality kidneys on the right or the best quality kidneys on the left. Again, probably because many of them are not being biopsied in terms of high quality kidneys, or many not being transplanted when it comes to the low quality kidneys. So again, you can't interpret these odds ratios that I'm showing you on the next screen, but just know that different relationships among different kidneys is almost certainly due to selection bias. And the kind of purpose of this kind of data is to show you don't trust the retrospective data. So what can we turn to? The least biased retrospective data we have is from European implantation biopsies. So again, these aren't going to impact allocation, but they're really good, kind of a good case scenario to show the prognostic capacities of biopsies on transplanted kidneys, because there's no selection bias in which kidneys are biopsied or transplanted, because they biopsy all the kidneys and they've already been transplanted. And they're all these high quality biopsies. So what we're saying is, under best case scenarios, can we show an association between histology and outcomes? Unfortunately, they did not. So this is a huge data from France, from Peter Reese's group and Alex Lupi's group, so Penn and France. And what they showed was that in a multivariable model, only KDPI and donor-specific antibodies were associated with allograft loss. And if you look at the kind of the predictive capability of a model without histology, it's essentially identical to a model with histology incorporated. However, what I'd like you to pay attention to is on the left, I've shown you the characteristics of their cohort. They have very few donors, especially in their Belgian validation cohort, who had advanced glomerular sclerosis, advanced IFTA, or advanced vascular disease. In fact, only 2% with a higher degree of IFTA or higher degree of arteriosclerosis. So not totally clear that this matches the kind of kidney that we care about, right, in the fundamental question. And in fact, what they tried to do was look at when you match US kidneys to kidneys in France that had similar clinical characteristics, that the outcomes of these ECD kidneys, if they had similar outcomes to those of French kidneys, indicates they were very transplantable, had kind of acceptable outcomes that were explained by their clinical characteristics alone. Unfortunately, what makes this a tough comparison is that the comorbidities that are driving KDPI are not necessarily the same between European kidneys and US kidneys. And if you look kind of at the characteristics that I highlighted as examples, you know, in the US, high KDPI is largely driven by things like diabetes, high creatinine, whereas in the French derivation cohort that we're comparing it to, only 8% had diabetes, only 13% had a high donor creatinine, whereas more of them have things like advanced age that can drive up KDPI, but might not kind of be scenarios where we need additional clinical characteristics, unlike kind of advanced donor comorbidities. And like I showed you earlier, on the bottom there, the degree of chronic scarring is very different. And so the question is there any prospective data that's helpful for us that we can rely on? Considering that I just showed you a whole bunch of retrospective data that I'm telling you, again, many of it's from myself, most of it's useless, right? And so there's only really a single prospective study about using biopsies to guide allocation. This is from the New England Journal from 2006, the Ramuzzi group. And what they looked at was 62 transplants in which they used biopsies to guide dual kidney allocation. So in other words, this is a scenario in which we have a kidney of low quality, and we say, okay, we might offer it to a recipient as a 2-pack of both kidneys transplanted together because one kidney alone from this low quality donor will not provide enough kidney function. And what they did is they used histology to guide which kidney should undergo a dual transplant and which kidney should undergo a single organ transplant. What they found was that using this strategy actually allows these older donor kidneys who are older than 60 years old to have equivalent outcomes to younger donor kidneys because they're able to identify which kidneys are okay to transplant alone and which need both kidneys together to provide a similar amount of high quality nephron mass. So actually this shows that the strategy of using biopsies to guide this allocation was effective and provided better outcomes. Unfortunately, it's a single study that's very, very small. And that's kind of all we have. And so if we come back to the fundamental question of does this biopsy difference in this donor that I showed you, does it predict outcomes? My answer to that will be, we don't really know. My interpretation is probably yes, but we don't know for sure. And in fact, what might confuse you even further is that in this particular case I'm showing you, these biopsy results are actually the same donor, the same exact slides that were read by 2 different renal pathologists at 2 different hospitals. So clearly we have work to do before we can kind of incorporate this, and really prospective studies are needed. So in my last slide, I'll sum up for you that what we talked about was that over half the kidneys that are recovered for transplant are biopsied in the US. There's a lot of heterogeneity here. It's really unknown if getting a biopsy at all independent of results impact utilization rates, but it's probable that bad biopsy results do increase discard and good biopsy results increase utilization. We know that biopsies have poor reproducibility in studies that are enriched for lack of reproducibility, but so do gold standard biopsies, and that it's really not known to us whether biopsies carry prognostic value for the select group of donated kidneys that we kind of might want more information on. There's some data against the routine use of these kidney biopsies, but really perhaps it's best used when there's a paucity of other clinical data and we need biopsy results to reassure us that a kidney that we might otherwise not use is transplantable. But maybe the biggest take home is that we really need prospective data. Some of this is coming in studies that are ongoing in the UK, but really I think places like Canada, the the US and elsewhere, we need to take charge here and get some high quality prospective data to tell us what are we actually looking at. Thank you. I'll take questions now.
Thanks, Ali. That was a wonderful overview with quite a twist in the end. So, I mean, the selection bias is huge. I think our, and I, my transplant colleagues can correct me, but I think our biopsy rates are low. We only biopsy when we are, thinking, oh, this looks like a bad kidney, which, is a huge selection bias. So my bias coming in, and maybe you have reaffirmed that, is that maybe we should not biopsy until we know better. Is there anything that you would say that would counter that kind of approach?
I think from my perspective, I agree with you. I think if a kidney is otherwise going to be transplanted, and it's like, here's a perfect example. So we see all the time when we do retrospective results, I saw one that was like an 18-year-old healthy donor, creatinine 0.5, died in a car accident, biopsy. That biopsy is going to provide you no information, and you should trust that whatever you see is sampling bias, right? There's no way that anything useful is going to come from that biopsy. Whereas if you see a donor, limited medical history that we know of, high creatinine, and you're not sure if you want to use it or not, or you're not sure who you should go to, only use it when you really don't know what to do, because at that point you can only help, right? If you're not going to use it anyway, try to see if you can rescue it. But in other scenarios, it's just not clear to me why we're using the cost and why we're confusing ourselves with extra information that we do not actually need.
Exactly right. Dr. Karpinski.
Yeah, hi. Thanks, Husain. I'm one of the transplant nephs, and back in my fellowship for my sins, I did a project looking at kidney biopsies and creatinine, and looking at what predicted outcome in high-risk donors. I think the scenario, I just want to clarify I think we have quite a different landscape in Canada as compared to the US. Our discard rates, I do not think would reach that, the numbers that you're seeing. The number of offers per recipient, I think, are also far, far, far lower. And I don't unfortunately have any statistics on that. I don't think Stephanie's on the line and she would be able to tell us that either. So that might be really interesting for us to look at, just at those differences in behavior across two, otherwise, well-functioning healthcare systems. Could you comment a bit on the use of the KDPI? I know it's different, but KDPI is really a comparison of kidneys that were transplanted. So even kidneys that are at 99% KDPI, that we're just saying that they are 99% worse than all other kidneys were transplanted. I don't know that KDPI was ever intended to be used to prompt discard.
Yeah.
So what is the influence? I know it's not entirely related, but how is that added into the biopsy related discards?
Yeah, I think that's a great question. So basically, kind of, the intention was to provide this holistic kind of combination of clinical characteristics to say, okay, what is the quality of this kidney compared to others? But you're right, as the donor pool changes, and kind of I showed you both US and Canadian data, but as donor pool changes and we're getting more and more marginal organs, kind of scaling to the average donor kind of becomes a more complex question. And in fact, you're right that we know that there is a labeling effect in which KDPI can kind of discard utilization, and kind of the role of KDPI was associated with higher discard rates. And so some places use high KDPI to prompt biopsy. They say, okay, now I know this is a bad quality kidney, and so I should do a biopsy to get more information because I know it's bad quality. I think that's a mistake, kind of as you're saying. It doesn't really kind of serve as a useful allocation tool when it's based on kidneys that were transplanted. When it's scaled only to the average kind of donor, right, the median donor, so it doesn't provide us as much absolute data. When it doesn't tell us the kind of risk of using that kidney versus the risk of staying on dialysis, which is very real, right? In the US, 5-year mortality is greater than 50% after dialysis initiation. And also, it's not very good at predicting anyway. The C statistic, like I told you, 0.6. In the KDPI, many 11-year-old donors have a worse KDPI than a 70-year-old donor. So it's like a very flawed metric in so many ways, but you're right, it's become like very increasingly relied upon. And it's just an extremely flawed measure.
Thanks. And to go on that, yeah, we implemented KDPI a couple of years ago, or maybe longer now. But I remember, there were organs that I would have accepted without hesitation. That suddenly the KDPI of, mid-90s came up, and I'm like, that made me pause. And luckily, we had an internal discussion, and we still decided to, use KDPI as just one piece rather than as being the main decisive factor there. To Yolanda's point, again, are these possibly, the differences between Canada and US related to what drives the decision making? I know you have published separately on that topic. Here it's mostly nephrologists. In our center, it's us who look at accepting or declining an organ. At other centers, it may be surgeons, and there may be certain, looking at what do you say, metrics. I don't think there are metrics here, but we don't get influenced by that. It doesn't mean our right for transplantation will be taken away or something like that. I wonder if there is some cherry picking related to that. Could that drive the discard rates? And do you want to talk about that?
Yeah, I think that that there are major system differences that encourage poor utilization practice in the U.S. I tried actually very hard to find discard data for Canada and that national level for this talk, and I couldn't find it. If anyone has it and you can send it to me, that'd be really fantastic. But I think that I think one thing is that the donor pool is certainly different. So our donor pool definitely has more donors with hypertension and diabetes and kind of other advanced comorbidities compared to the Canadian donor pool, probably because we have a higher demand per capita for transplant than Canada. But I do think that kind of from a system level, we have a much more disorganized system of allocation. We have like you're saying, kind of a regulatory structure that really historically has made it very, very difficult to take any risk, because in our historical regulatory structure, you used to be based your kind of accreditation was only based on 1 year outcomes after transplant. Well, it's very hard to predict 1 year outcomes after transplant. And in fact, what's been shown is that when centers get flagged for poor performance, they become more conservative of their utilization, and actually their 1 year outcomes worsen because no one's actually really good at predicting 1 year performance. And so it kind of it worsens access to transplant, it worsens utilization, and it's largely a regulatory structure that's antiquated and not based on evidence, especially when we know, like we said earlier, that getting a transplant period is what matters. And what's been shown is that if you look at the worst tier graded centers in the US, they're getting a transplant there is still like 30% survival advantage over staying on dialysis at a few years out. So we're kind of incentivizing all of the wrong things, and as a result, can lead into this pressure to make decisions better and better that only makes you more conservative in a non-evidence-based way.
Absolutely. And I'll give the last question to Dr. Noor.
So thanks for your talk. We don't really have national discard data. So I'm on a working group that's a Canadian working group that's kind of looking at how to place the marginal kidney, sort of looking at a new structure of how we can allocate these kidneys nationally instead of just getting rid of them. So just I think for everyone else in the audience, one major difference in the US, the OPOs procure the organs, and then they speak to the transplant centers, right, about the offers. So you have a very defined discard rate because they've got the organ procured and then they either used or not. So in Canada, that's very rare. So it's very rare that they proceed with an organ retrieval if a team has not already accepted the kidney. So what we get here is sort of the clinical scenario. Are you willing? Yes or no, but the kidney has not been procured. And so we have these decline rates based on this evidence. So it's not really tracked very well nationally. So we try to get this data. So we don't really have that kind of discard data. And maybe, I know we're running out of time, but from my perspective, I don't think I've used an allocation biopsy in 10 years. And when we looked into this data in the province of Ontario, there had been less than 5 biopsies done in a 7 or 8 year period for allocation purposes. So the number of kidney biopsies are really, really low in Canada, like dramatically lower than the United States, order of magnitude. And I think where we're not using them is probably in the setting of AKI, especially in donors, if you want to see if there's cortical necrosis or not. And we're probably declining those kidneys that we should be using. But that's just, I think, a conservative change in practice in Canada. So I think that the way we practice and the use of biopsies are very, very different. So it's interesting to see because we're close in many other ways in transplant, but this particular area, we're very, very different.
Yeah, I think it's very interesting to hear that. But I think you're right. Like maybe I think the same thing should be done in the US. Maybe rescuing some kidneys that otherwise wouldn't be transplanted is really the best use of this kind of extra information.
Fantastic. Thanks again. Since we are running out of time, thanks, Dr. Husain. Thanks, Ali, for this excellent overview of the topic. For the audience, you will be getting an email with the evaluation links. Please complete those. And I'll stop here.